Hello, everyone. Welcome back to week 5, part 2 of 3 for our outpatient billing and reimbursement course. Part 2 focuses on chapter 10, which is clinical documentation improvement, medical necessity, and coding compliance. Two of my favorite topics. So, at the end of this chapter, you should be able to define those terms. And one of the things about the terms, a lot of them are terms that you've seen before. So, that's the really cool thing. Two, you should be able to describe the components of a coding compliance program, apply clinical documentation improvement, also known as clinical documentation integrity, to ensure coding accuracy, and then medical necessity, and then the case studies at the end of the chapters. Now, in chapter 7, 8, and 9, coding practice exercises consisted of statements for which diagnoses or procedure codes were to be assigned. And so the next step in that process is to ensure that coding compliance is met, that the documentation has integrity, and then making sure that medical necessity is met. On the day of your CCS exam or CCSP, you will be expected to apply concepts, those tasks that are on the outline for the different domains. And this is where the application comes to life, those case studies that are at the end of each chapter. So, accurate and complete coding really means that we got sound documentation, we're following guidelines, and that we're justifying what happened today and why. Now, these particular areas here, I would have to say, are really going beyond the basic day to day role of a coder, and so I want you to think about beyond today. Why? The world of coding is evolving. Artificial intelligence is coming into play, and I think that oftentimes we focus so much on today, we forget about tomorrow. Today is over. All right. So when we talk about coding compliance, I want to kind of take a step back to cover something that may not be as obvious in the chapter. So, from an organizational perspective, every organization should have a compliance program. So, let's take the coding part out, a compliance program. The Office of Inspector General has given us the 7 elements of a compliance program. One of those elements is routine auditing and monitoring, another is provider education. And so, coding compliance is where we're just carving out a portion of those 7 elements. And so, coding compliance programs basically are something that either the coding department would establish in conjunction with the compliance department, but it basically involves 3 things: written policies and procedures, routine coding audits, and then education and training. There are so many governmental programs that we have to comply with. And one of the things that I like to say is we need to know from a high level perspective what all of those programs are that impact us. But then instead of focusing on one program or the other, just make sure day to day we adhere to the rules. The 4 that they call out in the textbook is the CERT program, medical review, NCCI, which you've heard about before, and the recovery audit contractor, which I know you've heard about before as well. So, remember when we talked briefly about the NCCI? Remember we talked about, those edit tables. And so Here are some examples of the column one and the column two, right? Reported on the same day. And in this particular case, we're talking about mutually exclusive edits. And so, mutually exclusive edits are those situations where those two codes, two procedures are unlikely to be performed on the same day. Now, something I don't think that I've mentioned with you, but you should have seen this in the textbook, is that last column of the NCCI table where they talk about a modifier is added to one of the codes for payment consideration. So I want you to see for this table, there's 4 rows, right? At the end of each row, there is a modifier indicator, not an actual modifier, but it's an indicator of 0, 1, or 9 that lets you know if a modifier can be added, right? So for these 4 scenarios, a modifier could be added for payment consideration. And why do I say payment consideration? Right? Because they still have to approve the payment. All right. So then here is an example of procedure to procedure code edits. We've seen this before where the code in column two is basically um, um, a part of what is in column one, right? So column one is a more comprehensive code than column two. And let me just back up for a second because now I'm thinking about as I'm saying that I'm thinking about um that statement just to make sure that that is correct. So, procedure to procedure and I'm thinking this through as I'm talking. Procedure to procedure edits, right? Code pairs or edit pairs for which the code is a component column one of a more comprehensive code in column two, and they're only paying for the comprehensive code. So there may be situations when we can report both codes, and that modifier column will give us that indication. And I know I talked about this before, but it is very important that you go to the NCCI website. And you know what? Let me just pause for a second and show that screen just because I want to make sure that you know that you've seen it. And then also that you can look at the different areas. So, medically unlikely, right? You see the list here. Um, and they have some that are archived, some that are still in use, right? And then you have the procedure to procedure edits. And let's see what they say here. NCCI P2P edits prevent inappropriate payment of services that should not be reported together. Each edit has a column one and a column two. If a provider reports the two codes of an edit pair, so that's column one and column two, for the same beneficiary on the same date, the column one code is eligible for payment, but the column two code is denied. So, you know what? Another reason why I wanted to pull this up is because I think, and it just could be the wording, the textbook has it backwards. Um, because that was kind of like racking my brain as I was looking at the slides. But yeah, column one is the comprehensive code, and column two is the component. Something else that I mentioned to you that we started off with edits for the provider, and then we got hospital outpatient. So you see that reflected here. And there used to be, oh, it's still here. There is a manual that is organized by the chapters in the CPT manual. And then there used to be this other file, and I don't see it, but it was this really cool um, file that tells you, and you can tell I don't go over here because if I did, I would know that it was there. It tells you how to look at the tables. Well, let me just say this: because of some of the changes that are going on at the federal government level, some of these things may were formerly available, but not available anymore. And so I would just I would just I would make sure that I look at that now. So let me get back to my presentation, which I have just removed, but I just felt like I needed to take you there to that website, and you've actually seen, right? Um, what I was talking about. All right. So yeah, I'm glad that we looked at that because no one is perfect. There can be errors in books and on government websites. So, all right. So, the Medicare outpatient claims process involves NCCI edits. And so, when we're talking about the hospital bill, OCE, outpatient co-editor, is what is used to evaluate claims at the claim level. And so you'll see some of the edits that could trigger when it's looking at our claim form. And you can take a look at those. All right. Clinical documentation improvement, also known as clinical documentation integrity, is really a big thing. Um, I will tell you that a lot of people feel like, and the textbook actually tells you integrity as well. I think a lot of people feel like um, this function is carried out by nurses. However, there are health information management coding professionals that are involved in CDI as well. And basically what is happening is that CDI specialists are looking at the medical record documentation and asking questions in the form of a query about the documentation, which impacts code assignment. But as you should know by now, we don't query for reimbursement purposes. We query to improve the quality of the documentation in the patient record. The other aspect of a CDI program is DRG validation. And basically, what happens is the payer is validating the DRG that we assigned along with the codes to confirm accuracy. And so, one of the things that frequently happens is that we have to appeal denials that they've made um, based on what we believe is supported in the medical record documentation. Payers also conduct audits, and they conduct all sorts of audits. If a patient is concurrently in the hospital, maybe every day, they're looking at, does the patient still meet the criteria for hospital admission? They may also look at a situation where a patient is readmitted. Does that patient need to be readmitted? Can they safely be treated at home? At the end of the day, clinical documentation improvement, clinical documentation integrity is about improving the information that's in that medical record so that it um, provides us with a record that can be used for future care of the patient and reimbursement, etc. All right, computer assisted coding. Hot topic, hot topic, hot topic. So we talked about this before, but this is something you need to know for the CCSP exam. And so, computer assisted coding is where you have this software that utilizes natural language processing, NLP, which is something that we've used for a very long time to locate the diagnoses and procedures in the health record. And then it assigns codes. The role of the coder with the use of CAC is that we audit and validate what was assigned. And so there are some manual processes that take place, such as when a patient has trauma. And so there are lots of trauma hospitals across the country. And so this would be an example of a manual process. There is some, uncertainty by coders with the use of the computer assisted coding because, why do we have to check the computer's work? But the computer assisted software, just like other types of artificial intelligence, machine learning, it's eventually is going to get it right. So you have to figure out what role will you play. Medical necessity, very simply put, is um really justifying what happened today and why, right? Making sure that that diagnosis supports the service that was provided. There are many tools that can be used to assist with medical necessities, such as software. At the end of the day, we have that integrity with our documentation is complete, is accurate, is timely, it can support medical necessity. Additionally, we do have medical necessity criteria available in the Medicare coverage database. And the Medicare coverage database includes national coverage determination as well as local coverage determination. Now, I'm afraid to show you the screen again, but I'm gonna do it because I want you to see the website for the Medicare coverage database. I would encourage you to go over to this database and look up at Medicare NCD LCD. LCDs are published by the Medicare Administrative Contractors. NCDs are published by CMS. Okay, so definitely recommend you go over there. Why? On the day of the exam, you need to be able to apply these concepts, not just know and understand them, but actually apply them. One of the things we talked about previously was the advanced beneficiary notice, also known as an ABN. And this basically is when we think Medicare is not going to pay for the service. We have the patient sign it to say, you agree, patient, that you will pay for this service if Medicare does not. The other consideration is that auditing process, right? Reviewing the medical record with the claim from start to finish to make sure that we are meeting criteria. And then hospitals do have edit systems and process that is basically scrubbing the claim prior to it being sent to the payer so we can correct our own mistakes, right? You don't want to send out dirty claims because dirty claims indicate that there is some uncertainty or misunderstanding about the rules. So coding from the patient record is what must be done. Now, let me just be honest. Out here in these streets, there is some coding that's taking place without looking at the medical record, and that's a problem. However, the medical record has to support the medical necessity of the procedures and services that are being provided today, right? I also talked about the medical record is used to continue the patient's care from one provider to the next. It is utilized in cases, it is utilized in looking at the quality of care, research, you name it, the medical record can be used. And that's why that integrity has to be in place. So, something that you have learned in other courses regarding the format of the medical record, but one of the most common formats for progress notes are SOAP notes, right? Subjective, what the patient says, objective, what the provider observes and examines in the discussion and all of that. The assessment, the diagnosis, the plan, what they plan to do about it. Other reports that are in the medical record that we can use, definitely the operative reports, and then those diagnostic laboratory tests for services that patients have performed. All right, so um, what do we talk about? Coding compliance, clinical documentation improvement, also known as clinical documentation integrity, medical necessity and coding. We talked about coding compliance program. We talked about yeah, we talked about all of that. So, next steps, definitely do the exercises in the textbook and get yourself prepared for your homework and your exam for this week. And as a reminder, the lecture is not a substitute for reading the chapter.